Welcome everyone. I'm delighted to welcome you to the first of our breakout sessions over the 3 days. You've lots and lots to choose from, so I'm really delighted that you've come and joined us here. There'll probably be people drifting in, no doubt, over the next few minutes, but I don't want to eat into the speaker's time, so I'll get started. So this session is about recognising the central role of carers as part of the care team and how the carers are actually the lever for improving person-centred care. I was contacted by Pat Grogan from Family Carers Ireland last October when we launched the call for papers, and he set the challenge for IFIC and asked us, where is the carer in all of this discussion? In integrated care, we do tend to focus on the professions, we do focus on the systems that organise care for people, and often it is the people who are providing that care day in, day out that lack any kind of visibility in our discussions. Now, at IFIC, we really feel it is important to keep the patient and their care very central in all of our conversations, so we very much welcomed the challenge from Pat. So how we proceeded is we had a great meeting, we discussed the issues, and we agreed that we would co-design this session together. And we've had many, many meetings now over the last 6 months to get where we are today. We were also delighted then to be invited by Richard Mead from Carers UK, who's representing Scotland and Northern Ireland, and also by Julia Lanfradi from Eurocarers, and Sharon Anderson, who's coming to us from Canada, who had already submitted a paper to present and fitted absolutely perfectly into this session. So I'll stop there just to say we are always willing and wanting to listen to the voice of carers. We have about 50 patients, caregivers and citizens attending the conference for free, many more people joining online, and we need you as our network to tell people about these opportunities so that we can continue to keep our ears open. So I will now hand over to Pat Grogan from Family Carers Ireland, and he's going to set the scene for us, and we'll have a great conversation later on. Thanks, Pat.
Thank you, Fiona. And little did I think when I sent that email months ago, that it was going to end up here, which is absolutely brilliant, but it, demonstrates to me the openness and the willingness of the whole integrated care movement to welcome that challenge and the questions that are raised by people who are delivering services on the ground to family carers. I'd just like to introduce you to two members of my team as well. Over here I have Maggie on the right, who's our lead regional manager, part of my team, and Lynn as well is also a local manager in Cork. So they deliver services directly to carers on the ground. So thank you, Fiona, for the invitation today and the opportunity to address people. Hugely important subject and one that we're all very passionate about. I work with Family Carers Ireland, and my presentation will look at the inclusion of family carers in integrated care. So first, some statistics in relation to caring in Ireland. We have over 500,000 carers in Ireland, in the south of Ireland, and 67,000 of those are young carers aged between 10 and 17, which is a big number of children involved in care. 61% of carers then are female, 39% are male. And between the 500,000, they save the state up to 20 billion per year in care hours. So that's the equivalent of a health service in Southern Ireland. It's the equivalent, 20 billion. 95,000, nearly 96,000 people then receive a carer's allowance, which has a value of €248 per week for if you're caring for somebody under 66, and it goes up to 286 per week if you're caring for somebody that's over 66. There's 129, almost 130,000 family carers then in receipt of the Care Support Grant. 1 in 9 of the family carers juggle paid work with the work of caring as well in the home. And almost 4,000 people received what's called carers benefit. So those are some of the statistics. So who are family carers? Family carers care for loved ones, including children or adults with additional needs, people with physical and intellectual disabilities, frail older people, people with palliative care needs, people living with chronic condition and chronic illness, people with mental health challenges or addiction. So family carers provide continuity of care, physical, emotional, and medical supports within the home, while managing their own needs and the needs of a wider family as well. And in a lot of situations, you'll get people in a dual caring role, where they're caring for children and elderly parents. So a lot of pressure on family carers. And of course, people want to remain in their own home for longer, so which is right, and it's the safest place for people to be, and it's the happiest place for people to be when you're older, to be looked after in your own home rather than an institution. So why should family carers be included in the integrated care model? Well, family carers are the backbone of care provision in Ireland, but they are usually overlooked. Considering the current integrated care model, although the model mentions families, in practice it does not include or support the family carer. Family carers are named as playing a crucial role in all 9 pillars of integrated care, and in particular the pillars partners in care and shared value and vision. In practice, the role of family care is rarely recognised by professionals, and carers are not supported or encouraged to participate in care planning for the person they care for. There is no better time than now to ensure that the family carer, what people call the informal unpaid carer, is a key partner and supported in the integrated care model. So the time is right now to do it. So how do we do it is the thing, and I suppose one of the main things that we would see practically is collaboration, and consent then can be a little bit of a barrier. So we're talking about that as well, and how to try and overcome that practically. So to successfully integrate the family carer, a professional could, where appropriate, empower the patient, who is the cared for person in our language, to consent to have their family carer involved in the coordination and delivery of their care plan. And that's very important, and something that can be done quite easily, we feel, practically. So, and the value of it is huge, to family carers. It means so much to be included and to reduce stress, all of that. So this would enable what we call a sustainable caring routine, which is where the family carer can care well and also have a practical life and to have a healthy body and mind themselves, which enables them to care. So that's what we call a sustainable caring routine. Co-producing a sustainable caring routine with a family carer can only contribute positively to the patient. As Family Carers Ireland is the national organisation supporting family carers in the south of Ireland, we would also ask all professionals to refer the family carer to our services in Family Carers Ireland, or share our supports information leaflet with the carer and patient. And I suppose if this happens, you know, we have centres all around the country, we can easily distribute information leaflets that would point the direction to us so that we can support the carer as well in their role. So let's talk about the effects then of excluding family carers from integrated care, and unfortunately that's the practical side of what is happening at the moment. These are some of the effects experienced by family carers when being excluded from integrated care. No or poor communication, confusion, you know, on what is actually happening and how to care for the person, no information. Out of that then comes emotional stress, including burnout, because you have worry with that comes with that. Increasing the burden of care on the carer. You have physical stress, the feeling of isolation, you know, and not knowing and being alone, you know, at 4 o'clock in the morning when you're trying to care for somebody who really needs care and you don't have a team of people around you. You need as much information as can be got when you're with a professional. Lack of confidence in what they're doing because they're unsure maybe if they haven't been included. They might be unsure about the effects of medication or practical things that happen. And then relationship strain with other family members and professionals. You know, other family members might say to you, well, you're the carer, you know, you're in the position, you're getting the allowance, what's going on? How come this is happening? Or mum or dad doesn't look well. But if they're not included, they don't actually have the information. And like I said, there may be side effects from medication, anything like that, which could all be easily addressed if they were included in the integrated care model by professionals. So now we're going to look at the advantages then, and there's advantages for everybody in this by including the carer. So for the professional, it would reduce healthcare costs by minimising hospital readmission or other medical expenses. Very practical. Improving best patient care outcome by personalising care plans that are achievable with family carer involvement and support. And that's very important because people need to be included. I gave an example only this morning to another member of our staff, Nikki, and you know, a typical situation would be where there's an appointment for the public health nurse to come and visit the home, and the gentleman is being looked after by his wife, and of course he knows the nurse is coming, so he's spruced up, sitting down in front of a fry, and everything is brilliant, and when the nurse is gone, he collapses onto the chair and back into bed. You know, so people they need support, and the thing is they give off the impression that everything is fine when they go into a professional. So we need somebody there to support them. The encouragement of the patient by the family carer to follow through on the professional advice provided to the patient. I suppose that's during the visit, that when people go in to visit a consultant, and it can be pretty daunting, and especially if you're ill, you have to listen to the advice and the instruction being given. And if you get, you know, I know people are very good at it, but at the same time, if you have a second person in your corner that's actually able to hear the advice being given, that's tremendous because it can be repeated back to you in your home. And it's reassuring that it's actually happening. And it's reassuring for the carer and the patient. So that's very important. Sorry, I missed one there. 3-way collaboration between the professional, the patient, the family carer, focused on the highest quality of care for the patient to achieve the best outcomes. Appointments being kept and reduction of no-shows because the carer is on top of things and planning and arranging appointments. That has to be done. A lot of the time the person being cared for needs assistance in doing that. Monitoring of a particular condition by the carer and feedback to the professional, which is very important and valuable to the professional, we would see. Because, you know, feedback on medications and monitoring of behaviours and things like that can be very useful. So advantages for the patient. support with the physical and mental health challenges, sharing concerns and worries, shared understanding of the condition and treatment, health collaboration, people in this together, transparency, making the most of the time with the professional and the advice being given. And that's very important because it's so difficult to get in to meet the professional now that you have to make the most of the time that you have with them. We see that as hugely important. A family carer can listen, hear, and clarify information, which can sometimes be difficult for the patient. A family carer can encourage a patient to avail of the supports being offered. When they're in doubt or when they need that little bit of moral support, that's very important again. Being at home for longer in a safe environment and appropriate support for the patient and the carer. That's through the referral to Family Carers Ireland, that we can support the carer in making sure that they're at their best and that they're being supported and understand how to care best. So that's the point of the referral to Family Carers Ireland. The advantages then for the family carer: ability to work towards a sustainable caring routine, access to the appropriate support through ourselves, involvement in the care plan and proactive care planning, inclusion, of course, feeling valued and acknowledged as part of what is happening, clarity around the person's condition and medical needs so that they can be supportive, information from Family Carers Ireland post-referral on how best to create a sustainable caring routine. Excuse me. So, the last slide, Family Carers Ireland and Integrated Care, we're calling on professionals to do these basic things: to recognise the value of including the family carers where appropriate, to collaborate with the carer, to ensure consent with the cared for person, to normalise the integration of the family carer in their professional practice, and to actively refer carers to Family Carers Ireland. Thank you.
Thank you, Pat. What fantastic service Family Carers Ireland are providing. Next up, we have Richard Mead from Carers UK. He is the Chief Executive for Scotland and Northern Ireland. And in a past life, I actually had the pleasure of organising the 5th International Conference for Carers, Global Conference for Carers, which was hosted by Carers UK back in 2009 in Leeds Castle, and it was a huge event. So this work has been going on for a very, very long time, very important work, and Richard is going to come and talk to us about the experience in Scotland. Thanks, Richard.
Thank you, Fiona, and I hope my boss isn't watching on the live stream because you just promoted me to Chief Executive and she might have something to say about that. Actually, my name is Richard Mead. I'm the Director of Carers Scotland, which is part of Carers UK, and we're a charity that is working towards a society that recognises, values and supports carers. And we generally use the term unpaid carers. Pat referred a lot to family carers, but it's pretty much what we mean is the same thing. Again, biggest challenge of the day is sticking to 15 minutes, so I'm just putting my timer on. Just a little bit of context. In Scotland, there are nearly 800,000 unpaid carers, and that represents about 1 in 7 of the 5.6 million people that live in Scotland. But it's a really high turnover population as well. So actually in Scotland, about 340,000 people become a carer every year, and about the same number stop being a carer. So it's a really sort of changing population, and that adds huge complexity to the experiences that carers have and how they come and interact with the systems that they need to. And of course, the roles that carers have and the context they have can be hugely different and very variable. And I think the really important thing to understand is that the vast majority of people in Scotland are predicted to become a carer at some point in their lives. So caring is an issue that really should concern everyone in society. And the same as in Ireland, unpaid carers make a huge contribution to the health and social care system in Scotland. It's estimated that the replacement cost of the health and social care that they provide would be around £13.1 billion. And to put that into context, it's the Scottish entire health and social care budget for next year is just short of 20 billion. So it's pretty much fair to say that without unpaid carers, the health and social care system in Scotland would simply just collapse. So they must be considered equal partners in care. And for the reasons some of the reasons that Pat gave, carers are vital in that coordinating role of the person that they care for, including everything from managing appointments to social care packages, staffing, treatment, hospital visits, as well as managing and supporting discharges from hospital. They have vital knowledge of the person they are caring for, often not just who they are as people, but also their concerns, their conditions, their wishes and desires, as well as the support and treatment that they are receiving as well. And this is essential knowledge for any care planning. And policy ambition in Scotland is pretty much similar to other parts of the UK and in lots of other parts of the world. We are seeing this shift in focus from acute settings to the community and home settings. And that's largely reflecting patient needs and wants, as well as creating greater efficiencies in healthcare systems. But in order for that to work, that really puts a lot of pressure and makes the role of the unpaid carer absolutely crucial, as they provide so much of that care once somebody moves into a community and at home setting. And carers become advocates for the person they are caring for. They negotiate services and support, and that can be particularly the case for those with mental health conditions and neurological diseases. And carers may have powers of attorney for those they care for, which in practice should give them an even more and bigger role in the decision-making around the care that that person is receiving. And then the evidence base out there that has been done, the evidence base around carers could always be bigger and more, but the evidence that exists does show that caregiver involvement in care planning does help with smoother transitions between levels of care and institutions. It does show that actually outcomes are improved and care quality is increased. So it's hugely significant. And I'm going to talk a little bit about Scotland as an example where we've got a policy and legislative infrastructure that has been good at recognising that carers make a huge and important contribution as equal partners in care. And this concept of equal partners in care is not a new idea for Scotland. It's actually been around for a long time and was recognised even in the 2010 carers strategy, as well as the most recent one that we've had. We've got health and social care standards that have been published in Scotland, which sets out what people should expect when using health and social care services, and it includes a principle that unpaid carers are treated as equal partners in care. And these are strong policy statements and documents that all health and social care services and staff should know inside and out in Scotland, and particularly the health and social care standards, because that's about expectation of care. There have been other initiatives as well which have put supporting carers as equal partners in care. There's a national framework that's been developed by our National Body for Education and our Social Services Council, which is supporting social care staff, and that is developed toolkits for that workforce to help them identify carers, to have better conversations with carers that can hopefully lead to better outcomes for them and the cared for person. And in Scotland, we had, in 2016, a landmark piece of legislation, the Carers Act, and this actually put, in principle, on the face of the legislation, a requirement for giving carers a legal right to being involved in discharge planning from hospital. And the Act stated that carers should be involved in strategic decision-making at a sort of a bit more at a macro level, so at local board level, so they should actually be involved in strategic planning, but really importantly, at a local level, at an individual level, being involved in hospital discharge processes around the person that they're caring for, particularly when that person has ongoing support needs to where they're being discharged, whether that's home or care home. This legislation was that unpaid carers and lobbying groups have been calling for and working towards for a long time. So it's seen as a huge step forward and hopeful at the start of a genuine partnership between unpaid carers and practitioners. It's been 8 years since the Act was passed, and I'm going to talk now a little bit about what it's been like a bit in practice. Carers Scotland, Carers UK, we do, we try and monitor implementation of that act to see how well it's working. And as part of our ongoing work, we produce every year a survey called State of Caring right across the UK, including in Scotland. And it's a huge survey covering every aspect of caring, but also includes specific questions around experience about being involved in discharge planning and questions around being involved in that process around the care for the cared for person. And last year in Scotland, we had over 1,700 carers respond to that survey. And it showed that despite the legislation and policy that we have in place, much of what carers experience in practice is far from being considered equal partners in care. Of those that responded to the survey that had someone discharged from hospital, 6 in 10 were not informed or involved in decisions about that discharge. And about, even worryingly, only 20% were actually asked about their willingness or ability to provide care, and just 18% said they had received sufficient support to protect their health and well-being and that of the person that they're caring for. And only 20% received an adult carer support plan, which in Scotland is a plan that every carer is entitled to support them with their caring role. And this suggests that just many carers are not having those vital conversations about their role in care and the support they need to carry out that caring role. And actually these figures, we do this survey every year, these figures have not improved in the last few years, suggesting sort of limited process. And as part of this survey and our work with carers, we asked them to describe their experience of being involved in care planning. And the overwhelming picture is a challenging one. Carers talk about being ignored by practitioners in all settings, so whether that's in the local setting with the general practitioner in primary care or actually in the acute setting in the hospital. And this can take a lot of different forms. Carers are just not recognized or identified as a carer by a practitioner who then doesn't engage with them in any meaningful way. Others describe being ignored because despite being recognized as a carer, because there's a practitioner knows best mentality. One carer recently described to me that they felt ignored and passed off because they had been emotional at the hospital where her mother had been admitted, and as such were not involved in any of the care decisions, including the one to discharge her, which is obviously directly in contradiction of the legislation. And carers talk about the person they care for being discharged without them being involved at all, including another carer that told me that they had a phone call that the person that they were caring for would be coming home and would be discharged at 7 o'clock that night. They had no plan, no other service in place to support them, and the carer felt it was put entirely on them to provide that care at home, whether they were ready for it or not. And lack of support comes up a lot, particularly around discharge planning. The person being cared for may be fit for discharge from hospital, but that doesn't mean they have the support packages in place at home to meet their needs. And carers talk about a lack of support or discussion around what is needed for that cared for person, but also critically for themselves as carers. And that just puts huge pressure on the carer. Even when carers have had a power of attorney in place, they have not always felt involved in decisions that relate to the person they are caring for, which again contradicts the Carers Act, but actually also the Adults with Incapacity Act. So overall, despite the promise of legislation and policy, the reality is that carers in Scotland, and for the most part, are still not treated as equal partners in care, which is hugely disappointing for all of those of us who work to see such policy and legislation, and even more disappointing for the carers who feel undervalued, under-recognised, and most of all, not supported to carry out that caring role. And I've just got a few quotes here to sort of show you some of what people have experienced, and this assumption about being at home and people being left out of the conversation, and no formal assessments being taking place, nobody asking questions about what's needed and what's helpful. And we know that there are consequences to this lack of engagement and decision-making with carers. And these consequences can be devastating, ultimately leading to a breakdown in care and a hospital admission for the cared-for person, or an admission to a care home, which may be sooner than hoped for, or carried out at a point of crisis rather than in a much more managed way, which people would have preferred. Carers feel undervalued and under-recognised, which can have a huge impact on their own health and well-being. This, coupled with the additional burden of care that carers describe as a result of a lack of good care planning, can have a huge impact on their physical and mental health. There's a whole raft of evidence that shows that when compared to non-carers, carers experience significantly poorer physical and mental health outcomes. And again, our State of Caring survey found that over half of carers said that their physical health had suffered because of their caring role, with 1 in 5 actually suffering a physical injury as a result of their caring role. It also found that over a quarter of those that were surveyed described their mental health as bad or very bad. Carers have clear rights in Scotland about being involved equally in the care planning of the person they are caring for. So these rights are just not working for carers. And here you can see some of the consequences, again from quotes, and I think similar to what Pat was identifying, multiple admissions, people being sent home without any support, being put directly on the carer, people having to take up other options, so ended up in a respite bed that had to be paid for privately. So why is this not working in Scotland? What are the barriers? In order to be an equal partner in care, a carer needs to be identified as a carer. Either they need to self-identify, they need to realize it themselves that that's what they are and that's what they're doing, or they need to be identified by the practitioner to enable them to participate in the decision-making process. Our research suggests it takes 2 years on average for a carer to realize they actually are a carer. And obviously during that time, they can miss out on huge and valuable support. And it might only be the point of crisis in which they do realize, and at that point of breakdown, which is obviously then becomes a much more complicated intervention. And as well as not always being able to identify a carer, it's fair to say that practitioners can also be guilty of not truly understanding the role of a carer and the extent of what a carer does. They don't see those carers that are doing the 90 hours a week of caring. They don't see the role that they play in supporting that person at home. There is fragmentation in the system that can lead to lack of communication between different stakeholders and partners in care, and that can lead to assumptions over who's doing what. For example, acute practitioners potentially making assumptions about what social care is happening in the house, and there actually being none. Clearly, there is a lack of understanding amongst practitioners, not just about the value of ensuring carers are equal partners in care, but also about that legislation and policy. Some of this may well be down to the huge pressures that we're seeing in the system at the moment. There is a lack of workforce in both health and social care settings. There is issues around capacity in acute beds in Scottish hospitals. And we have heard repeatedly about decisions being made about hospital discharge purely because it's about freeing up bed space. And that has negated any view that the carer might have about whether they should or should not be discharged. And although this pressure on resources is no excuse, it might at least explain why. The question then is, what do we need to see change? We clearly have a policy and legal framework in Scotland that is there, but how do we make it a reality for the vast majority of carers rather than just a few? Firstly, and perhaps most importantly, we need to do more to recognise and identify carers, either supporting the carer to realise that they are a carer, or through practitioners proactively identifying carers when they come into contact them. And the earlier in the carer's journey, the better. This can enable better understanding, planning, and support. Practitioners really have to be proactive here, whether it's the GP in primary care, the pharmacist spotting somebody coming to pick up a prescription, or whether that's somebody in the hospital following an admission, perhaps say after a terminal diagnosis, or even a car crash where there's going to be ongoing mobility problems. In terms of directly involving carers in planning and as equal partners, then practitioners not only need to understand the law and government policy, as well as receive any appropriate education, training and support to make that happen. I feel it's really fundamental that they get that there are resources and tools to support those practitioners, but the time and space to be able to understand and learn and to have that interaction with them so that they can be in a better position to respond to carers. And actually, carers themselves need better support, training, and education. As equal partners in care, as well as the planning, they also need to be at the heart of the delivery of that care, whether it's personal care or indeed medical care. They need to be better supported to do this and to do it safely, especially as more carers will be expected to provide more care in the future as this shift to community settings for the majority of our care takes place, and as our population becomes more complex with multiple health conditions, as it sort of mostly lives to an older age. And we definitely need more research. I think there's a huge gap in research around support for unpaid carers, and building that evidence base will help make a compelling case. And why does it matter? Just very quickly, I know I'm very short on time. Well, I think, again, Pat mentioned quite a lot of this as well. There is emerging evidence to show that involving carers as partners in care has positive outcomes, both for the carer and the cared for person. Smoother transitions, better support at home, packages in place. It enables carers to feel empowered and in control of their caring role, which is obviously hugely positive, not just for them and their mental health, but also in their ability to keep caring. And ultimately, it supports a better health and social care system, as supporting carers to be equal partners in care ensures that integrated care is truly integrated and not excluding one of, if not, its biggest contributors. And that is such an important message to take away. So I think ultimately, to conclude, it's about a legal and policy framework is really important to have, but actually it's about getting the hearts and minds of those practitioners and everyone involved in the system to really recognize and value the role that unpaid carers make, so that actually we can deliver better outcomes, not just for the person being cared for, but their carer too. And that is me. Thank you.
Brilliant. It's great to see such fantastic considered work going on in Scotland. Next up, we are hearing from Canada. Canada has been a country that really has put patient and caregiver involvement to the forefront of our thinking at IFIC. We were privileged to bring the conference virtually to Canada in 2021, where we introduced our Patient and Caregiver Award for the first time. And we are actually going to Calgary in October. So I'm delighted now to introduce Sharon Anderson from the University of Alberta, who will tell us about your experience over there. Thank you.
All right. Thank you, Pat. Thank you, Richard. Great introduction, and I'm going to build on that. So this is my third IFIC conference, and I'm so pleased to talk about Canada's caregivers. Family caregivers are the care integrators, recognizing carers in a patient-centered health and care system. We're asking for system and culture changes, structural changes in policies, practices, and resource flows, relational changes in relationships and power dynamics between carers and healthcare providers, policymakers. And we really need that transformative change in mental models, because without that, nothing is going to happen. So we're talking about, Carrie and I and Nikki are talking about this in session 4L. We'd love to have you. We've got three objectives in this presentation. Recognize carers' pivotal care role, understand co-design in education development, and introduce our education. So the assumption is that healthcare providers provide most of the care. In fact, family caregivers do most of the work. Professionals provide supplemental care. 1 in 4 Albertans, about 1 million family caregivers, are carers. They provide 90% of the care to people living in the community and assist with about 15 to 30% of the care in long-term care. And guess what happened in the pandemic when the carers weren't there? The system really failed. So that care in Canada is worth $97.1 billion, and as Richard and Pat said, that's 32% of the entire Canada health budget. So the system would fail without family caregivers. Now, caregivers do a lot of things, and I just want to particularly bring your attention to number 3. 50% of caregivers are doing medical tasks that nurses and doctors would traditionally do in healthcare settings. Also, have a look at number 6, being on call. Professionals expect family caregivers to be on call 24 hours a day, 7 days a week. Just discharge that patient home. There's the carer. They'll take care of them. And number 8 is the structural burden of care. Carers now spend 15 to 50% of their time managing health care, those appointments, coordination, all of those kinds of things. And you never know when that's going to spring a leak. So, as Richard and Pat have told you, family caregivers, a greater and greater percentage of them are feeling overwhelmed. And it is not care work, the actual caregiving that's stressful. It's the work and the worry and being overwhelmed with too much work. Exactly the same as healthcare professionals are talking about. That's what's happening to family caregivers. So it's risen significantly. So why more anxiety, distress, and burden? Notably, it's not, it's that longer care trajectory, the imperatives to move care home to communities and reduce healthcare costs have all increased care work for caregivers. And I'm not going to go into this more. Supporting family caregivers improves enhances population health. Caregiving is a social determinant of health. We need to talk about caregivers' health as well as the patient's health. It contributes to healthcare savings, it increases the experiences of care, and contributes to health equity. So we have been co-designing with and not for. We have a co-design team of 150 people, caregivers, healthcare providers, healthcare leaders, some of whom have been with us since 2014. So what you see in this is that we have the voice of intent, people with passion and motivation to take action, people with authority or mandate, policymakers, to drive that change, the voices of experience, the family caregivers, and the healthcare providers who also have experience and need to be part of that change, the voices of capability. Everyone in our team has transferable skills. Don't discount those family caregivers. They've got business, all kinds of experience that we can all benefit from. And we have the Learning Design Studio at the University of Alberta, so that voice of design. Our work started in 2014, a group of doctors who saw that caregiver distress was rising, and so they started to ask what caregivers needed. And initially in 2014, they really thought that just a little bit more training for family caregivers, maybe some peer support, that those need to be more common, that would be it. And in 2017, one of the family caregivers stood up at the conference and said, "You are not listening to us. Stop trying to build a better caregiver. We know how to care. What we need is healthcare providers to support us. The healthcare providers need to be trained to support family caregivers." And so in 2018 and 19, we developed a competency framework, and then we started to develop education for healthcare providers. Now, when we started this in 2014, that was unheard of. This is a 2020 article from the Canadian Family Physician, and guess what the editor of Canadian Family Physician is asking for? Education for healthcare providers. So what happens is, I just want to take a little bit of a definition detour here. We talk about person and family-centered care, but really that family-centered care doesn't really attach to a caregiver. And so we coined the term caregiver-centered care to talk about family-centered, about person-centered care for family caregivers. There's 6 competency domains, and as you can see in the mountain slide, we really validated those competency domains and the competency framework in a modified Delphi process. So all of our work is underpinned by research. Our stakeholders recommended 3 competency levels for healthcare providers: foundational education for everyone, all healthcare providers, all social care providers, an advanced education for the leaders and healthcare providers who worked a lot with family caregivers, and a champions module, or champions education, where they would spread and scale education. So our education is now free online. The champions module is just coming online. We're just in the process of evaluating it. And I want to give you a taste of our caregiverscare.ca. This is an introductory video from the Advanced Education Domain A, recognizing the caregiver role, and it really gives you an idea and gives healthcare providers an idea of what family caregivers do.
I'll see you on Wednesday, Mrs. Fawcett. Oh, hi, Chad.
Hey, how did Mom do today?
She's getting stronger. We had a good session. We'll have another on Wednesday.
Cool.
Looks like your family's home.
I didn't think it happened. She lifted her stick and I got it in. Chad, I scored a goal.
Good for you, Carly.
Well, run up and tell your mom. I'm sure she'll want to hear all about it. Hi. Are you one of Leanne's nurses?
PT, physical therapist. My name's Natalie.
Hi, I'm John Fawcett. And you've met Chad over here. And that whirlwind that went rushing past you upstairs is Carly. How's Leanne doing?
Good. Tired, though. She's frustrated that stroke recovery can be so slow.
We're all frustrated with that.
Chad, adjust. We all depended on Leanne. She was always so healthy. The stroke has been like a thunderbolt for our family. It's still pretty new for all of us.
Of course. Recovery isn't just hers, is it? I should get out of your way now. You have your hands full.
Oh, you have no idea. Carly has hockey 3 times a week, and she has skiing lessons on the weekend. Chad's on the swim team, which means early mornings. We're all on different sleep schedules. Leanne needs help eating. She needs help getting from room to room. Mostly, I carry her. I sort through her pills, and I pick up the new one at the pharmacy. Chad's given up his bedroom for the rehab equipment. He's sleeping on a couch in the basement now. Carly needs new glasses. The roof is leaking. Car needs repairs. We've lost Leanne's income, and I'm not always able to work from home. We've been to the clinic and the hospital twice each this month. And when Leanne's asleep, I worry that she's having another stroke. She gets frustrated with me when I can't understand what she wants. Well, I get upset too. Yesterday, I found her in the kitchen crying because she'd forgotten how to make a sandwich. So, can you help with any of that? Well, thanks for all that you can do.
So education and training are recognized strategies to bolster evidence-based practices and change mindsets, the culture and context of care. So how do we reach healthcare providers' hearts and minds? That's exactly what Wendy Duggleby said we had to do in 3 to 5 minutes. So let's have a look at the appeal to change mindsets in the Competency 6, Changing the Culture and Context of Care.
In every passing decade, the quality and availability of healthcare to any ailing citizen has improved. And yet, even with all our ever-advancing knowledge, there remain pockets within the system that demand our attention, calling for positive change in attitudes and behavior. The world of caregiving is in fact one such area yearning for compassionate update.
As a healthcare system, we have a long road ahead. It's not difficult to find family caregivers who tell stories about failed care from the system, or such muddled communications between the family caregiver and the healthcare system that, on occasion, a measure of harm resulted, rather than the intended care. We can do better. Not only better, but by partnering with family caregivers, we dramatically improve the quality of care, period.
When I began my career as a physical therapist a couple years ago, I came into the healthcare world thinking I had already learned a great deal. I mean, the schooling, the practice, the details. I felt like I was well prepared for my career. And I was, academically speaking. But then I started working with people, actual caregivers, taking care of their parent, spouse, child, or dear friend. And I ran into a few situations that I couldn't have imagined of when I was a student. I wasn't trained to deal with the staggering concerns of the people surrounding my clients. I didn't understand how much pressure was on the caregivers who lived with my clients, whose care responsibilities were much bigger, much more demanding than I could have expected. I was naive. In a real way, the healthcare system has been naive too.
So right from the go, we've used the Kirkpatrick Bar Healthcare Evaluation Framework to evaluate our education. And we are measuring it at all levels. We're just working on the last one now. Since November of 2020, we've delivered 11,002, well, actually it's over 12,000 hours now, and we have reached almost 9,000 unique providers. You can see they're very positive qualitative quotes, talking a lot about slow down, listening to caregivers, exactly the kinds of things that we want to see. The other thing that happens is the qualitative result or quantitative results mirror the quantitative results. Healthcare providers always rate themselves really highly on these pre-questions they think they know. But when they do the post-evaluation, they say, I've really learned a lot, and in our evaluation on t-tests, we've got not only a significant difference, but a large effect size. This is the partnering module. So circling back on key points, because this is my last thing, so the contributions and negative challenges and negative impacts of caregiving are well documented. Caregivers are allies and partners in health and social care. You've heard that time and time again. They need to be supported and included as partners in integrated care, and that takes education for health and social care partners. Thank you very much.
Thank you, Sharon. And I thought that video was great, actually, because there's nothing like seeing real-life story come to play. So thank you for that. Before I hand over to Julia Lanfradi, just to remind you, if you want to put questions in the app, you can, or we will have roving mics going around and we'll get to the discussion part of the session. So next up, we have Julia Lanfradi from Eurocarers, and Eurocarers are a representative body of both academic and care organisations. So she's going to reflect on what she's heard and maybe give us some of the European perspective. Julia.
Thank you. Thank you for the kind introduction, and thank you, everyone. As Lynn has said, I'm here today. Sorry, Fiona. I'm here today to give a brief overview of the policy perspective from Europe. Eurocarers is a membership organization that is based in Brussels, and that is actually brings together grassroots organizations working with and for informal carers, and also research organizations. We normally talk about informal carers. Our definition really overlaps with the definitions that have been used today, so family carers or unpaid carers. So I'm going to continue saying informal carers, but just to say, just slight variation in terms of terminology. We have been working with informal carers in the past 15 years across Europe. Our members are in the EU, but also other countries from the broader continent of Europe. And what we have noticed working with them for the past 15 years is really the fragmentation of the level of recognition and support that informal carers have across the different countries. The EU is able to provide some guidelines and some guiding principles that member states can put into practice, but they still retain a considerable level of autonomy when putting things into practice. So when hearing my presentation today, do keep that in mind. The situation varies considerably across the different countries. The work that we do, as I briefly said, is to work closely with European EU institutions to build advocacy and to improve policymaking around the role of informal carers. And we also try to strengthen capacity locally with the organizations that are our members. So trying to work on those two levels. The presentations that we have heard today really capture really well what are the key asks of the carers movement, the key asks that have been brought forward in the last 15 years of advocacy and really trying to influence policy making. I have summarized them here in a few points. First and foremost, the importance of recognizing the value of informal care, both socially and also economically, as it has already been said today, the system would collapse without the role of informal carers. It would not be possible to meet all the care needs without their role. And this is something that governments and institutions need to recognize. The integration of carers as equal players in care systems is another key point that the carers movement has been advocating for a long time. And it's very interesting to be here today to reflect on some of the progress that has been achieved or that we still have to achieve to do better in this sense. Empowering carers in having their voice heard is another key point. It's very important to involve them in designing and building policies that will impact their lives. So trying to build systems in place to capture their needs and for us to be able to listen to them. And also making sure that care is a choice. Not only becoming a caregiver is a choice, but also for people that are in need of care, that are able to choose the care pattern that best suits them. So empowering everyone to make sure that care really is a free and independent choice that is not constrained by circumstances or lack of alternatives. What we have also learned working with the carers movement is the importance of using a comprehensive approach to policy making, really, without focusing only on just one aspect, but trying to tackle the issue of informal care from different points of view. First and foremost, making sure that carers are able to care for themselves, because without that self-care, it's not possible for them to be able to sustain the weight of informal care. So making sure that there is emotional and psychological support in place, mental health support, that there are also initiatives to promote their physical health and well-being, that respite care is provided, and that information and training are provided consistently across their whole carer's journey. Another key point is, of course, addressing their socioeconomic vulnerability. A lot of informal carers are actually, are actually forced to reduce their paid employment in order to become carers, or to reduce considerably their participation in paid employment, and that puts them into a vulnerable situation financially, both in the present moment, but also in the long run in terms of their ability to access pensions, for example, when they reach the retirement age. And also, as I mentioned earlier, having their voice heard, so making sure that politicians know how to listen to informal carers and are motivated and pushed to do so, really. So all this has really taught us that in order to bring about policy change, it's important to think creatively and think outside of the box in terms of how, in terms of identifying the right policy entry points. So not only focusing on health policy, but also keeping into consideration economic policy or work-life balance measure, and at the same time, employment policy and pensions. So all of these are useful entry points that can be used to advocate for better decisions around the recognition and support of informal carers. Now, in terms of the policy progress that has actually been achieved in the last few years, some progress has been made, but it has been quite fragmented and far from sufficient, as we have heard. Carers still don't feel like they are equal to practitioners when it comes to the role that they play. So there is still lots of work to do. But we can say that in the last few years, the COVID crisis and the aging population across Europe has pushed for some relevant policy changes. And first and foremost, in 2022, the European Union launched the Eurocarers strategy, which I'm going to talk about briefly. The Eurocarers strategy, as I said, was launched in September 2022 and was welcomed quite warmly by the carers movement because it does take into account some of the key asks that the movement has been advocating for a while. For example, it focuses strongly on long-term care, and it does recognize explicitly the role of informal carers. For example, the need to ensure a better interface between informal carers and practitioners, and also on for example, the importance of providing training and counseling for informal carers, providing respite care, and also providing adequate financial support for carers so that they are not facing poverty while being carers. The strategy focuses strongly on quality, affordability, and adequacy of care, and also on the working conditions of care professionals, of course. These two categories of players are interconnected. So while there was a lot of enthusiasm around the EU care strategy, it is also important to keep in mind that the strategy is a soft policy measure. What does it mean? It means that it is a framework for progress to be implemented at national level by EU member states. This is because the EU does not have legal competency on long-term care. The responsibility to implement policy change remains within member states. The EU can provide some high-level guidelines or principles on how to ensure that this policy progress at national level goes in the right direction. So, for example, some of the ways in which this is done is through exchange of plans and fostering dialogue among member states, but also by building relevant and comparable statistics and data, for example, building common indicators around long-term care, but also through funding. The EU does allocate funding to long-term care that can be accessed by states. Also recommendations on governance and quality principles. So these are other key points that should be kept in mind by member states. And finally, some of the key steps that the care strategy tries to implement in very practical terms are, for example, the national coordination of long-term care coordinators that have been appointed by each member state, but also an exchange of plan to improve policy at national level. So each member state should have national plans that will be shared with the European Commission, but also mutual learning that is fostered by dialogue by the European Commission, and also working on common indicators. So this is something that is being worked on in very practical terms. And yeah, all this will be reported back to the European Commission by 2027. Thank you.
So now we have some time for discussion. While you're thinking of your questions, you can either put up your hand and a microphone will go around, and I can see some questions coming in on the app as well. But I wanted to start maybe with Family Carers Ireland. Something that you said to me during one of our meetings was about when somebody becomes a carer, when somebody recognises themselves as a carer, isn't always at the point of diagnosis. So there's a journey that the carer goes on. What is your general experience of people who are coming to your services, and what has the experience been like for them to date? And if you could give a care journey the ideal route, how would you like the system to support the carer from that point that their loved one goes into medical care?
Yes. I suppose the journey of the carer is really quite simple, and it happens just out of everyday life, really. You know, things creep up on you as a carer. That's our experience from talking to carers. And I suppose it starts maybe with, you know, needing help with some tasks around the house, you know, and a hand here and there in everyday life. And then it goes from there maybe to meal preparation, and it builds from there naturally. And then as people get older, they get more dependent. And so the role actually creeps up. And usually it's probably left to one person in the family. And because we're all so busy, everybody else seems to pull back and leave it to the person who's actually in the position to be offering that help initially. So the person gets, as time goes on, the person gets more isolated, I suppose, and things are left to them. And then we're all too busy to actually upset our own lives and our own routine, and we have enough to be doing. And then I suppose, it can be hard for people then to actually get involved, and the fear of becoming involved and committing even, and people withdraw and they leave the care isolated sometimes. And it can be very difficult then for the family carer who maybe other siblings visit the home and, are inquiring about the condition of mum and dad and, did they lose weight and are they eating and what are you giving them? And it's those practical things that actually affect the carer then. And the carer, we find a lot of the time the carer feels guilty and it's a visit. We have to encourage them to say, well, this family member is in a position to actually help you here and you're not taking the opportunity. Sometimes it can be as simple as that, to actually include other family at an early stage and talk among the family to ensure that everybody is contributing. The allowances themselves do not pay for, and with today's economic situation and the pressure on families to own a home and run a family, the pressure is on for two people to be working. So that's really difficult, and it makes it twice as difficult when people actually withdraw. So based on our experience in supporting carers, we're able to bring carers in and have a conversation with them using a tool called the Carers Outcome Star. And that goes around that talks about the 7 areas of caring that we would consider and is considered in the STAR. And the 7 areas are, I wrote them down here in case I forget: health, the caring role, managing at home, time for yourselves, how you feel, finances, and work. So the sooner the carer can actually get to a care organisation that's able to support with those difficulties, that's the sooner we can help them to get organised. Unfortunately, a lot of the people only get to us when they're not coping and when they're in crisis. And that's why, that reinforces the view that really the carer needs to be identified early, and the people to identify him are the professionals, the GP, the consultant, the staff in the hospital, the chemist, as has been said, that they are in a position to actually identify the carer early and put them in touch then with the care organisations who can provide the support based on the experience of previous carers, and to get them so that you actually help them to try and build a caring routine before the crisis happens. Now, of course, you can't avert all crises, they will happen. But as the caring role grows, if they're aware of it and they take a step back and look at their own situation and what advice they might give a stranger, I mean, that's the way we try and get them to look at it. And then, of course, we have all the practical supports that are there. We'd have free counselling, we'd have emergency respite, we'd have information and training and videos. But again, the key to it is referral, and referral to the organisations who can support them, and a building of awareness. I suppose one little bit of feedback from a consultant recently, where Lynn and I were down in Cork, the professional said, well, and he was talking to the other professionals in the room, he said, really, sure, we don't ask, because we know that the supports are not there. So we don't open that can of worms in relation to support. But I suppose, to get back to the question, early intervention, early awareness that this person is involved in family care, things are going to progress and support is needed. I don't know if you would add anything then, Lynn or Maggie, to that.
Yeah, the only thing I would say about it in practice is you have to just give the person the information. At the end of the day, I think because a carer mightn't be ready for that support at the level that they meet maybe the professional, I think sharing the information is key. and then let the person come back when they need to come back, but at least they know the information. You know, you talk about when should you know, try and identify a carer, or when should it be done. Actually, that comes back to the carer themselves, you know, and the journey that they're on. But I think if we are able, as professionals, to be able to give the information and let them decide then to dabble into the supports that are needed, then I think that's a working model, you know, because I think you can control all scenarios, all families, you know, in it, you know. That would be my opinion on it, Maggie, I don't know.
Great, thank you. Sharon and a lot of the speakers alluded to it, but there's something about the expert role of the carer as part of the care team that's not being recognised. And I'm actually mindful of my own family's story, where my mother had, she had gone through her diagnosis, and I got access to her notes. And basically, during her first part of her treatment, I got to see what the notes were about the patient. And there was a little column, and it just said, has a husband. And that was the only kind of social notes that were in her records about what kind of support she had at home. Now, her husband actually was quite a scientific person and was going to be a great carer and was taking notes every day of her treatment and doing everything the right way. But this lack of knowledge really around kind of what expertise is available in the home seems to be lacking as part of that early conversation around the patient treatment. What, Sharon, do you think can be done at that professional patient interface around recognising the role of the carer early on?
Well, I think, as Richard said, the research is showing that only about 20% of caregivers are asked if they want to care about their care, any of those kinds of things. And it really needs to be a routine thing that happens. You know, if somebody is there in the hospital or they've been diagnosed with something, do you have somebody that cares for you? That person should be noted on the chart. They should be asked if they're interested in caring, what they're doing. And then that should be followed up on. That should be part of the continuity of care. Caregivers are the largest healthcare workforce. We just don't recognize them as such. And that needs to happen in healthcare, and it needs to happen early and throughout that continuity of care. In Alberta, we've been asking to have the carer recognized on the chart. There are probably about, what, Isabel, about 10 or 15 different names or recognition of different roles, but not necessarily the caregiver. You know, next of kin, all of those other things, but who is actually the caregiver needs to be noted on the chart. There's a significant difference, we think, between people who have caregivers and who do not, and there's lots of kids now that are not having families, and they're not, you know, who's going to care for them, sort of thing. But we need to know, even from research, what's the difference between those people that have caregivers and who don't? Because if we don't know that, we don't know the value of caregivers, what they're doing, all of those kinds of things. And healthcare providers need to be part of that data gathering as well.
I was going to ask Richard a question about the winning of hearts and minds, but actually there's a question that's come in for you here. There is mention that carers themselves need education about their role in Scotland. Has anything already been developed that could be shared with other organisations?
Well, yeah, there is. I mean, lots of resources out there. I think the problem is and certainly happy to share via slide deck and add that to it. I think the challenge is not so much that there's the resources out there; it's actually being able to reach people to make sure that they have access to them. And again, that goes back to that identifying carers. So, I think as Pat said and others, is that it's at the point of somebody becoming a carer, their needs might be quite light. It could be a case of just going in, checking in on the person they're caring for. They might not even live with that person. It could be for a son caring for an elderly mum, and but over time that gradually increases to their lifting, they're carrying, they're doing medical care, they're doing personal care, they're doing all the other bits and pieces. And actually it's then that they might need access to some of that information, or certainly before. So it's less about the availability of the resources. There's lots of stuff out there from organizations, everything from YouTube videos about safe handling and lifting and other support. But I think that it's how do we get that to unpaid carers to see it? How do we get that as part of their planning process and actually sitting down with carers when they are identified and talking through what actually that journey might look like. Because for some, it will be very different on carer to carer, depending on who they're caring for and what the condition that the person that they're caring for has, and that I think is the critical bit. Is that identification, and there could be more done, I think, as well to support carers with some as part of being that part of that care team. About again, I hear of carers having to manage medications, and a lot of the time they don't feel like they get the support, whether that's from the pharmacist or from the district nurse or whoever. So actually, there's potential of more support and education, and perhaps that should be something that is looked at as part of supporting somebody through a caring role.
I might stick with you, Richard, and go back to that hearts and minds of the workforce. What is it that can be done? Because you tried to introduce legislation, you've got the Care Act, you've got Carers Act and so on. You don't feel really it's had the success in terms of your statistics around actually what has happened at the interface. What can be done by organisations or otherwise to win the hearts and minds of the professionals and clinicians that carers are coming into contact with? Or not?
If I'm honest, it's a system response we need. I think part of the reason why carers are often unidentified or ignored, as they describe it, not getting that sort of conversation, is because there's so much pressure in the health and social care system right now. And I hear this from carers, is that actually they're literally told, we need that bed, that person's going. And that's the end of the conversation as far as they're concerned. And now I don't believe for a second that the clinicians and the practitioners that are surrounding that discharge, that's their mindset in terms of how they deal with people. That's the pressure of the system that's ultimately causing them huge stress and trying to clear a sort of a bed for the next person to come in. So I think actually, as a system response, we need to look at and that's come up already in conversation in the other sessions, we need to look at how we invest in our workforce, both in health and social care citizens. A proper health and social care workforce that is properly invested in, valued, respected, well paid, and has the resources will probably look a lot different for a lot of unpaid carers in terms of the support they then get. But I mean, and as a side to that, I do think there needs to be more awareness work done with practitioners because they are just focused on what's in front of them and not necessarily who's sat next to that person. So there's a bit of both, is looking at the system and making sure actually we do more as a society to respond to health and social care as a system. But then obviously on top of that, there is education and development work with practitioners. Again, pharmacists, I think, is a really good, we've come up a couple of times now, it's a really good point of contact. Carers are often in there picking up prescriptions. And how often does the pharmacist just think, oh, I recognize that person, they're here for the 5th time this week. Maybe there's a conversation, they don't necessarily have that. And is it about supporting pharmacists, a bit of education, awareness? And again, the other system issue is, if you identify a carer, what do you do next? If you don't know where to go or there's nowhere for that to be referred onto, then you're almost opening a can of worms and not being able to do anything about it. So I think there's that concern for a lot of practitioners as well. I know this person's a carer, but I have no idea where to refer them to. And if I do refer them to somewhere, actually, are they going to get any support? Because right now in Scotland, a lot of social care teams are only dealing with carers at point of crisis. So that low-level intervention that we might want to see at the point of being a carer isn't really there at the moment.
I think you're really right about that role of pharmacy, and on a day-to-day basis when carers are dealing with so many medicines, having their local pharmacist as someone that they can ask a stupid question to that maybe they're not as confident in asking the consultant about when they go in for that official meeting is a security for carers that's possibly not recognised correctly. Sharon, I think you might want to have come in there. Really, I think it was the physiotherapist who was talking really about the shock once she had qualified and coming into the home, that she hadn't really considered that she would be part of people's lives.
That's certainly the case, you know, that we're hearing from the people that take our education, especially the champions now. We've got about 70 people that have done the champions education before we put it online for general use. But they're saying that, this has made a tremendous difference in our practice, and that's what we want to hear. And also, talking about we need to spread and scale this as well. So yeah, reaching hearts and minds is they actually need to be educated about caregiving in professional training and the professionals that are out there still need training. And yeah, the other piece, because we've just done a study with 85 family dogs, and the navigation piece, we don't know where to send them if we ask them, is a huge issue.
Thanks, Sharon. Pat, we talked a lot in our conversations as well about transitions in care and about discharge. And is there any part of the system that you can see would play the most critical point in how they work with carers and communicate better with carers? Is there parts of the system that we absolutely need to get right to improve outcomes for the patient?
A number of years ago, there was a report produced on discharge planning in the Irish Health Services, but it was never actually implemented. And it was a great document in that it started the discharge planning on the date that the person came into the hospital and followed the person right through the hospital and was concentrated on a proper discharge of the person with all the help and support needed. But the plan was never implemented. And it had staff identified who would be available to speak to carers before they were actually discharged, which was brilliant. It was a great policy if it was implemented. But the people that were actually in those positions became bed managers. That's what happened because of the economic situation. So managing the beds, as Richard has said, we have exactly the same problem. And discharge planning became managing the beds, trying to get people out. And there are awful stories. You know, I know of a carer who the person was sent home. They were on oxygen in the hospital, and the oxygen arrived 3 days after the person was discharged. Things like that happen. People don't know when the discharge is going to happen. It happens without their agreement, and people are discharged, have been discharged in cases where they should not have been discharged. And the way that it has gone, there's so much pressure on the beds that it seems that people are discharged to just get the bed free. And if the person has to come back, which they know they probably will have to come back, they have to come back through A&E and face up to 96 hours on a trolley in A&E, which is the point at which you're admitted back to hospital. So people are discharged that are on a high risk of actually being brought back to hospital almost immediately. That's the case in some cases because the pressure on beds. And why is there a pressure on beds? Because we've actually closed the step-down beds. They're nearly gone. And all of the carers that the HSE did have in Southern Ireland is shut down. The beds are shut down. They're gone. They'll tell you that the things are in practice. We'll say if you identify a hospital, and this has happened to me, to say that, you know, well, we still run that service, and they do, but the beds are reduced to 1 or 2, so they're not there. And then the whole privatisation is probably linking into that. And privatisation doesn't always work because people are in the private business to make money. And the beds that are available are there to be kept going and kept moving and kept full. So like when it can be very difficult, you know, to get a person out into a nursing home bed from the hospital based on their care needs, which can be expensive to manage, and that's another factor in the whole thing. So the system needs more investment in the right areas, and even for the likes of ourselves as a carer support organisation, if one of the biggest things, I suppose, if carers were referred to us, we'd find it difficult to cope with the resources that we have, unfortunately. But it's I suppose it's the chicken and the egg. You know, you've got to actually give people information, put pressure on the establishment, if you like, to provide more resources in that area, because healthcare and difficult healthcare and supported healthcare is something that we're all going to need. You know, and we've got to make the system better. That's, if that answers your question.
Yes, and there's actually kind of it's a similar question, but I might open it up to the rest of the panel. It's how do we address, from Breeding Kerry, how do we address the growing dichotomy between the expectation of home-based care and limited availability of community-based and home-based care? There's a significant supply and demand challenge that is going to grow internationally. So does anybody want, Sharon, would you like to come in there in terms of how do we get that balance right between formal care in hospitals and elsewhere and that home community-based care?
So in Alberta, what we have is we're doing a whole healthcare reorganization, but Corinne Shum, the Assistant Deputy Minister of Continuing Care, says that if we continue with the current system, and Richard said this too, it's not sustainable within 8 years. If we continue to admit people to long-term care, we have to move much more of that integrated care closer to home, into communities, and caregivers and integrated care are imperative at this point. There's no other solution. We need to make sure that this system works, and how do we do that? And we need to do that together. It needs a collective impact approach. Carers organizations are definitely part of the solution, but healthcare needs to work with carers organizations.
Richard, the community and voluntary sector in Scotland has generally been well received. Is that continuing to be the case? How is that power balance in your experience between the community and the home side of things driving the conversation versus the government system led?
Yeah, I mean, I think the third sector does do an awful lot, and we've got a strong independent sector in social care as well. But I think, I mean, that's sort of going back to the question about, there is an expectation actually in home settings about what a person would want. And actually an interesting dynamic that we don't often talk about, but is often there, is that expectation might be different for the cared for person and the carer. And again, it's usually the cared for person's expectation that is the one that we seek to meet, and not the carers. Before I worked at Carers UK, I used to work for Marie Curie, which is a charity that supports people who are terminally ill, and a big part of that is about supporting people to die at home if that's their preference. And often you would come across carers' expectations being, I don't want this person to die at home because of the pressure on me to be a carer when I just want to be a husband or a wife, or actually the association of memory. But the person who's dying was like very much, this is where I want to be and this is where I want to die. And that managing that tension was often just ignored, and the focus was put on, well, the person who's dying is the person that gets the preference. And I think we see that a lot in a lot of settings about care, is that sort of the sort of propensity to move towards the cared for person is the priority and gets all the expectation, and the carer has to sort of fit in around that. And I think that is something that we should look at. And again, it's around how that carer is identified and how their needs are met and how they're planned for as well. Because again, carers should get care plans for themselves in their own right. It shouldn't be an attachment to the cared for person, because they have their own cared for needs. So I think there is, going back to the point about there is that sort of this disconnect between expectation about what home care or care in the community looks like for both the cared for person and, really importantly, the carer.
Thank you. Juliet, is that resonating with you in terms of what you're hearing across Europe? I mean, getting the carer voice into research projects, you're involved in quite a lot. What has your experience been like recently?
Yeah, definitely. My experience definitely resonates with what has been shared today. And I think, if I may add a further reflection, I think one of the key points that policy has been focusing on, but progress has been a bit lacking behind, is the income support or economic support to informal carers. Because yes, they are unpaid carers, they are doing it outside of a professional capacity, but they are giving up on income to do so. And if we do not make up for that in some way, it is not sustainable for them in the present moment and in the future, when they are going to be needing care themselves and when they are going to be needed to retire. So I think it's a difficult point to tackle, because obviously this requires government to spend money to give some kind of carers allowance, or even more indirectly in terms of giving them carers leave or other types of services that can make up for their loss of income. So it is difficult to advocate for it and to kind of bring about change, but I think it's a very important point that we should keep fighting for because it's essential.
Richard, do you want to come back?
I just wanted to add, because we're in Northern Ireland, and actually I also cover Northern Ireland as well as Scotland, and actually just on that, we have in Northern Ireland the Carer Poverty Commission, which we run, and actually carers being not being able to work as a result of their caring role is the biggest driver of poverty and carer poverty in Northern Ireland. So it's hugely significant, and yeah, the lack of financial support facing carers in Northern Ireland, carers' allowances are pittance, and not every carer gets it, and that has a huge impact on that household and their ability to sort of provide support and well-being.
Quickly add, this also disproportionately impacts women, and it's a great driver of gender inequalities in poverty. So yeah, another element to keep in mind.
Sharon, if there was one thing that you'd like to see happen in Alberta or the wider region in Canada for caregivers, what would that be?
We in Canada have not had a national caregiver strategy. That was just promised last year in Canada's national budget. But we in Alberta have funding to do an Alberta caregiver strategy. So we're working at all of those levels in that triangle, and we're just really fortunate to be able to work with some excellent healthcare providers, and the government is actually listening to us as well. So I think it's that overall work together, carers organizations, healthcare providers, social care providers, because caregivers need transportation and those caring communities as well. We need that asset-based community development. So everything.
I'll leave the last word to Family Carers Ireland as you got us together here today.
Thank you, Fiona. Yeah, I suppose I was thinking about what's the most important thing we would ask for, and what we're asking for is the recognition of the family care by professionals. They do excellent work, but I think to just have that awareness, build it into your routine, to ask, is there a carer that supports the person? And if there is, would they like them included in their care and in their care plan? And I think that consent is very important. I think that this is the one area that we're kind of lagging behind in. We have strategies and policies on a lot of stuff. The income is a little bit better in Southern Ireland than it is in the South, and across Europe it varies. But the referral is really important, because if the carer is made aware that there's support there, as Lynn has said, that gives the carer the choice, that they know that there's somebody else there that they can tap into for support. Information is power, so if you give them that power, it enables them to build a sustainable caring routine and to try and avoid crisis. So the professionals, on top of the excellent work that they do, if they could add that to their resume, that would be absolutely brilliant from our view.
Wonderful. Thank you so much. So I'd say thank you to all our presenters and for your time in leading up to the conference in planning the session. I really enjoyed it, and I want to hear lots more from carers around integrated care in the future. And thank you for your questions. Thank you.